done? Okay. Let's start with the lower extremities. And let's start as distal as we can.
Dorsalis pedis.
Dorsalis pedis and
Posterior tibial.
posterior tibial pulses. Yeah, those are, what do we call those pulses? What are they referred to as?
Pedal pulses.
The pedal pulses. All right, so let's come more proximal. What's the next palpable pulse as we move up the extremities?
The popliteal.
Popliteal. Then as we keep moving proximally,
The femoral.
femoral artery pulse. That's correct. All right, so that's how many? That's 4? Okay. Let's do upper extremities. Right, well, we're going to start distally.
The radial.
And ulnar, then brachial,
Then axillary.
and axillary. Yeah, so upper extremities. That's 4. All right, what else? Now let's go head and neck.
Is it the internal carotid that you
Internal carotid and, yeah, if I palpate below the level of the larynx, I'm palpating the common carotid. If I go above the superior aspect of the larynx, then what I'm palpating is internal carotid artery. Now, there's a branch of the external carotid that you can palpate up by the temporal region. It's called the superficial temporal artery. That would be 11, but we didn't include that in our list. All right. I'll point out something. Typically, blood flow in an artery or any vessel for that matter is what's called laminar. Okay? Blood flows in layers in such a way that the blood flow in the center of the vessel is most rapid, and because of the effects of friction, blood flow peripherally is a little bit slower. But the blood flows in a laminar fashion like that, so that each of these layers is parallel to each other. Laminar blood flow, as we depict here, is silent. Meaning that if let's say my common carotid or my internal carotid artery is perfectly patent and free of any type of disease, okay, if I place my stethoscope, the diaphragm with the stethoscope on my neck and listen, am I going to hear anything? No. It's silent. Now let's suppose you have a stenosis. What's a stenosis?
Right.
What does the word stenosis mean? I've used the word already.
It's where like a valve doesn't close.
Okay, so when we talk about valves, it's a narrowing in the valve orifice. It doesn't open fully. The term stenosis isn't specific for valves. It just means a narrowing. So if I have a vascular stenosis, what I'm really saying is that the blood vessel is narrowed like this. And it might be because there's an atherosclerotic plaque with a lipid core in here. That's the most common cause of vascular stenoses. A narrowing like this, a vascular stenosis, is going to create turbulent blood flow. That means that as blood flows through the narrowing, the stenosis, it creates little eddy currents like this. Okay. That turbulent blood flow created in this case by the stenosis is more noisy. So that if you place the diaphragm of the stethoscope over an artery that exhibits a plaque or a stenosis, you're going to hear a sound called a bruit. And a bruit is going to sound something like this. So with each pulse of blood flow, you're going to hear a little noise, a little muffled sound that's caused by this turbulent blood flow. So oftentimes you'll see that when a person comes in with a stroke, part of the physical exam is to place the stethoscope over the carotids and to listen for any bruits. God bless. Why do they do that? Well, because many strokes originate from a plaque within, let's say, either the common or the internal carotid artery. This is the line of the wall. And then what happens is that plaque can rupture, can break, and a thrombus forms at the site of rupture, like this. And that thrombus can either disrupt blood flow, causing the stroke, or it can break loose. A little piece can break loose and travel downstream. That gets lodged and thus occludes blood flow. What do we call a little piece that breaks loose, by the way, from a thrombus?
Embolus.
We could call it an embolus or a thromboembolus. That's breaking off from a thrombus. So if someone presents with a stroke, part of the physical exam is going to be to listen, to auscultate over the carotids to determine if in fact there is a bruit, because of the presence of a bruit may signify the presence of underlying atherosclerotic disease. Let's see. Let's just label this a little bit. Let's say this is the right femoral artery. Here's the right deep femoral artery. Here's the right SFA. And let's say down in this region here, this is the region of the popliteal fossa, so this would be the right popliteal. Now, one of the most common sites for peripheral vascular disease is the superficial femoral artery. In fact, the superficial femoral artery passes through a little tunnel to reach the popliteal space. It's called the adductor canal. Okay. And as it moves through the adductor canal, it passes more posteriorly to reach the popliteal fossa. Well, it's within that adductor canal that oftentimes you see disease. Atherosclerosis that can either in and of itself occlude blood flow, or atherosclerotic disease that undergoes rupture that leads to thrombus formation that occludes blood flow. It's very analogous to what can happen at the carotids. You know, atherosclerotic disease caused by plaques are prone to rupture. And when they rupture, they form thrombi that can occlude blood flow. So let's say you have a vascular occlusion here. You have a plaque that ruptures and leads to a thrombus which occludes blood flow, like this. Okay. If that lesion is present in the superficial femoral artery, what's going to happen to the popliteal, dorsalis pedis, and posterior tibial pulses? Right, so what's going to happen to the pulses?
You're not going to feel them.
They'll have absent pulses. Right. How does this patient present who suddenly develops a plaque rupture and thrombus formation? How do you think he presents? What kind of symptoms? Well, what brings him into the hospital? What do you think is the first thing?
High blood pressure?
Pain. Pain. Ischemic muscle is painful. Just like if you have an ischemic cardiac muscle, it's painful. It causes angina. Okay? So the patient comes in with pain, and when you inspect the lower extremity beyond or distal to the area of obstruction, what are some characteristics? What are some findings that you would note on physical exam with respect to that distal lower extremity?
Absent pulse.
Absent pulses is one. What else would you notice about the lower extremity?
It's gonna appear pale.
It would appear pale. Yes, it would lose color. It would appear more pale. What else would you notice?
His foot's asleep.
What's that?
His foot's asleep.
Say it again.
His foot's asleep.
His foot's asleep. Can it get numb? It can. You can develop numbness or paresthesias. But the other thing is to touch,
It's
it's
gonna
going
be
to be
cold.
cool. It's going to be cool because you're losing blood flow. So this is an emergency because if you don't restore blood flow right away, what's going to happen?
He's gonna lose it.
He's going to lose the leg. Once the tissue dies, it's dead. You can't replace that tissue. So the patient's going to probably be brought for an emergency angiogram where you can advance a catheter into the femoral artery, and through that catheter you can squirt dye that's going to outline the vessel, okay, and the area of stenosis. It's going to tell you exactly where the obstruction is located. And then there are several options. You know, you might perform thrombolytic therapy to try to dissolve the clot. You might perform an angioplasty and put a stent in there. Or you might do an emergency FEMPOP bypass. What's a FEMPOP bypass? It's a bypass from the femoral artery down to the popliteal. Okay. Now, it can be from the superficial femoral. They're still going to call it a FEMPOP. They're going to take a segment of vein, or they're going to take some type of synthetic graft, a tubular structure, and they're going to connect the proximal end here, the distal end here, so that blood bypasses the area of blockage. Now, once that blood then bypasses the blockage, what happens to the pulses?
Your turn.
They're restored. Okay. When that patient then returns to the recovery room, there are going to be orders to send that patient to the intensive care unit because it's important that the patient be monitored very closely for the next 24 hours. The next 24 hours are a period during which this graft is subject to thrombosing, clotting. Okay. If you can get them past that first 24 hours, you usually do well. So the vascular surgeon is going to write orders to check pedal pulses like every 15 minutes for the next 4 hours. Okay? And then, you know, after that, like every hour for the next 4 hours, and then, you know, until morning, whatever. He's going to write some schedule to check the pedal pulses. Now, sometimes you have a lot of patients in the ICU, sometimes you don't have many patients in the ICU. So one night, and this was at Truro, we had a night where it was very quiet, weren't many patients in the ICU, and there was a patient who had undergone a FEMPOP bypass. And so the patient went to the ICU where there was just one nurse that night, and the orders were to check the pedal pulses on a regular basis. And so sometime that evening there was a change in shift and a new nurse came on. And she read the orders and she went to check the pedal pulses. And she noticed that the posterior tibial pulse was absent. So she looked back in the previous nurse's notes and noticed that it was present before. Now it was absent. And she calls the nursing supervisor. And the nursing supervisor said, well, use a Doppler to check it. Maybe you simply can't palpate it, but there's still some flow. So she puts the Doppler over what she thought was the posterior tibial pulse, and she doesn't hear any noise, any sound. So she calls the vascular surgeon and says, listen, I need to inform you that the patient's pulse is now gone. So he said, okay, let's notify the OR. Let's let anesthesia know, and let's prepare to bring the patient back because we want to open this up right away. So the OR crew all comes in. They take all these sterilized trays and they open them in preparation for bringing the patient back to the surgery suite. And the anesthesiologist comes in, the vascular surgeon comes in, and he meets the patient right outside the OR. And he puts his fingers along the posterior aspect of the medial malleolus, and he can palpate a posterior tibial pulse.
Oh, man.
And then so he calls the nurse stat. She runs up to the OR, and he says, "Listen, this pulse is easily palpable." And she says, "Oh no, I was palpating behind the lateral malleolus." Okay. Lateral malleolus. She didn't really know her anatomy. Okay. What do you think happened to that nurse?
Fire!
And
Black
She was
ball,
gone.
go.
And once you're gone, you're blackballed. It's hard to get another hospital job. Now, where you will get a job, though, is either a nursing home or sometimes a home health agency will hire you. But it's hard to get another job like you had before, because that's the way it works in hospitals.